Okay, thanks for letting us know, guys.
I think it's because we forgot to press start broadcasting. Can you guys see if you maybe just try and re-upload the slides now, Elena, and then we can see if they can see you again?
Can you see now? Oh, okay, sorry about this, guys. Okay, so maybe let's go back to the question, although you can see the answer. Okay, let's just talk through it, and the next one will be better. So from I'll break down the relevant parts of the question. So this is a young man who's presenting with abdominal pain and diarrhea. I have a 2-day history and watery stools. So watery stools, when you see this in a question, usually you can start thinking about diarrhea caused by amoeba. And then bloody diarrhea. Whenever there's blood in the stool, that means that the colon is involved usually. So this is a colitis, and actually when there's bloody diarrhea, that's usually caused by entamoeba histolytica or Shigella. When there's blood in the stool, we call it bloody diarrhea. We call it dysentery. And then there's a travel history, which kind of points us further towards an infectious cause of diarrhea rather than, for example, an inflammatory cause. And there's risk factors about contracting amoebiasis, which are eating food and swimming in contaminated waters. When you see this man, he's pale and clammy, and his blood pressure has dropped to 99/64, and he's a bit tachycardic. This can be caused by dysentery, especially if there's significant blood loss in the stool. And again, there's a temperature which points us further towards an infectious cause rather than an inflammatory cause. So over the next slide, we'll talk about different causes of diarrhea. Hopefully you can read that, but I'll send the slides out anyway. So when you have a question about diarrhea, you want to think about whether it might be an infectious cause of diarrhea. So in the previous question, we had a typical example of an infectious diarrhea, which was from a travel history positive, maybe a young patient with a fever who's had risk factors such as eating contaminated food. Maybe you'll hear in the question or in the case that they also have contacts who have the same symptoms. And infectious diarrhea can be bacterial, or it can be viral, like norovirus and rotavirus, or it can be amoebic. And then I have another slide coming up about how to identify which one of these it might be. Alternative causes of diarrhea might be inflammatory, such as IBD, inflammatory bowel disease that can be Crohn's or ulcerative colitis. Again, you can find them in questions as a young patient with new or worsening diarrhea. In UC, you're more likely to see blood in the stool. They can come in with a temperature and similar clinically, so hypotensive to the previous example, but there probably wouldn't be a travel history, although sometimes it's difficult to actually distinguish between inflammatory and infectious causes. Autoimmune causes of diarrhea would be something like celiac disease. Malabsorptive causes would be pancreatitis, where the digestive enzymes are not produced effectively, so you get something called steatorrhea. Stools are difficult to flush and foul smelling, typically in exam questions. And then you can get malabsorptive diarrhea caused by bowel resection, where the absorptive part of the bowel no longer has been resected, so there's large amounts of watery stool. It depends what part of the bowel has been resected as to the symptoms exactly, but post-surgery you can get diarrhea. That's common. Malignant diarrhea, so if you have a new malignancy, that can cause a change in bowel habit. And then functional, so people who actually have something like irritable bowel syndrome, they may describe their symptoms as diarrhea, but instead of actually it being large amounts of loose stool being passed frequently, they may be passing a small amount of stool frequently, or they might be, on the other hand, more constipated. And when these symptoms don't have an organic cause that we can identify, we call them functional. That's quite common in GP and in gastroenterology clinics. When you have a patient with diarrhea, how would you investigate them? So as per any unwell patient, you'd use an 8E approach. You do observations, you'd send off bloods, and you'd correct any abnormalities in the 8E assessment. So for example, if they were hypotensive, you'd give them a bolus of fluids, etc. And then if they have a travel history or an acute onset, you would send their stool for culture and microscopy. You'd be looking there for, you can look for ova, parasites, you can do a C. diff culture from the stool, you can do a PCR for viruses, all sorts of things you can look for in the stool. And then, whereas if it's a chronic history, so you're not thinking about an infectious cause, but more maybe an inflammatory and autoimmune cause, you can do a fecal calprotectin, which would be positive in inflammatory bowel disease. You could do a serology for celiac disease, so you're looking for antibodies in the blood. I've got some more information about that. You could do thyroid function tests. Patients with hyperthyroidism can have diarrhea, whereas hypothyroidism can cause constipation. You can measure the levels of B12 and folate to look for malabsorption. The diagnostic investigation for inflammatory and autoimmune bowel diseases are colonoscopy. So on colonoscopy, you can see exactly what pathology is going on in the bowel, and you can take histology samples as required. You do imaging. An X-ray or MRI or CT, it really depends on the presentation, and not all patients will require imaging, but it really depends on the presentation. But for example, in patients who present with a flare of inflammatory bowel disease, you would probably do an abdominal X-ray to exclude toxic megacolon. For example, if you have a patient with known, you realize that they have entamoeba histolytica, you don't need to do an X-ray in that case. So this is my slide that I mentioned with comparing the different causes of infectious diarrhea: bacterial, viral, and amoebic. Just in the interest of time, there's a lot of information there, so I'll let you look at that in your spare time, in your free time, but just like very characteristic or important differences to pick up. So the most common cause of infectious diarrhea is norovirus, and it has an incubation period of about half a day to 2 days. Whereas the incubation period for amoebas is much longer; it's weeks. And depending on the bacteria, it can also be a very acute onset with, for example, Staph aureus or Bacillus cereus, which is the one that's usually found in undercooked rice, to days, depending, for example, Shigella, cholera, etc. So really, if this comes up, you kind of need to do pattern recognition to determine which is the most likely pathogen involved. But these are just some general pointers as to how to distinguish between different causes of infectious diarrhea. Okay, this is the second question. Oh, no, sorry. I'm sure you didn't see that. So I'll give you a minute to answer this one as well. So a 23-year-old woman with a history of intermittent diarrhea, abdominal bloating, tiredness, and gradual weight loss present to her GP. There's no blood in her diarrhea or melena. Her GP arranged some investigations for her, which have come back as below. So we've got a hemoglobin, a TSH, an IgA, TTG, a fecal calprotectin, and a stool antigen for Helicobacter pylori. And this is one of the questions where, if I was in an exam, I'd be like, yes, I know what it is. And then it's a second stage question, which is, given the most likely diagnosis, what would be the most likely finding on histology? So would it be a presence of granulomas? Would it be a crypt abscesses? Would it be villus atrophy and crypthyperplasia, pseudopolyps, or ulcers? Okay, I think most of you have answered now, so we'll move on to the answer. But actually, first, let's go through these findings in her blood tests or her investigations in general. So she's her hemoglobin is 100. So it's not too bad, but she's anemic. Her TSH is normal, which points us away from, for example, the hypo or hypothyroid picture. Her IgA, TTG are positive. So that means that she has antibodies to tissue transglutaminase. This is very indicative of celiac disease. Fecal calprotectin is normal, and Helicobacter pylori 2 antigen. So that's just ruling out other potential causes. And given the most likely diagnosis, i.e. celiac, the most common finding on histology would be villus atrophy and crypt hyperplasia, as mentioned by the majority of you. So well done. This is what we've already said. So celiac disease is an T-cell mediated autoimmune disease of the small bowel. The risk factors include family history and these HLA types, DQ2 and DQ8, and there may be a history of other autoimmune diseases such as thyroid disease, hepatitis, type 1 diabetes. Presents as it did with this patient with fatigue, weight loss, change in bowel habit. In children, they can have faltering growth as well. You diagnose it with, initially you do a tissue transglutaminase antibodies and also total IgA, because in some patients, if you don't measure the IgA, you may get a false negative result because they might have low levels of IgA, they have IgA deficiency. So you have to compare the level of tissue transglutaminase antibodies to their baseline level of IgA. Otherwise, you don't get an accurate result. So you have to do those paired tests. But the standard diagnostic test is a biopsy of the duodenum, where you'd find villus atrophy and crypt hyperplasia, and also some increased intraepithelial lymphocytes. So what you see here is, this is a simplified, obviously, schematic version, but instead of having these lovely big villi, they're atrophied, whereas the crypts, there's hyperplasia of the crypts. So it looks flattened out, and the absorptive function of the bowel will be affected, obviously. If that is easy enough to manage, you have to have a gluten-free diet. Obviously, patients have to stick to it, which isn't necessarily straightforward. Complications of celiac disease would be osteoporosis, anemia, peripheral neuropathy, and they have a functional hyposplenism, so they should receive the pneumococcal vaccine as they're at increased risk of infection. I've just got a slide here quickly on IBD. I think this is quite well taught at most unis, so I won't go into it too much, but I like to make tables, as you've seen, to compare key features of different conditions. You see, your ulcerative colitis affects the colon only, and it can cause colitis. And in colitis, as we've said, you can get blood in the stool, so it's more likely to present with PR bleeding. Whereas Crohn's is less likely to present with PR bleeding, but it's a mouth to anus distribution, so it can present with mouth ulcers, and they can get ulcers in the anus, which can be very painful. And Crohn's, I always think, is a little bit worse. Obviously, UC is also not. It's an awful condition to have, but I always think Crohn's is a little bit worse because you can get fistulas and strictures. You're more likely to need surgery, and if you do have surgery, it's more difficult surgery because it's a more distributed area, as opposed to in UC where the colon only is affected. So you can just do a panproctocolectomy or just a colectomy to remove the affected colon, and the rest of the bowel will be absolutely fine. Okay, so this next question is about the next topic. So just to summarize, just diarrhea. We have a lot of patients who come in under general surgery with PR bleeding, change in bowel habit. most patients who come in under surgeons tend to get a CT pretty early on, and there's a non-specific finding of bowel wall thickening. So it can either be colitis, or it can be small bowel wall thickening, or sigmoid colon thickening, and then at that point is when you have, okay, your undifferentiated diarrhea colitis picture. What is it going to be? Is it an infectious cause? Is it an inflammatory cause? And ultimately, you do a lot of investigations while they're an inpatient, but the diagnostic investigation there would be a colonoscopy. And with celiac disease, you don't usually see patients who come into hospital with that, because it's more of a chronic kind of brewing disease. But you might see that more commonly in GPs or in pediatrics with children. Okay, so the next topic is about dysphagia, so difficulty or pain in swallowing. So in this question, we have a 41-year-old male presenting to his GP with an 8-month history of difficulty swallowing both fluids and solids. He also describes the regurgitation of undigested food, particularly when lying flat, and he has some occasional chest pain centrally. He has lost 3 kilos of weight over this period. His past medical history includes hypertension, and he takes amlodipine. So again, this is one of those 2-step questions. So if you know the diagnosis, that's great. But what is the most appropriate next step? Would you do a full blood count for this man? Would you refer him for an upper GI endoscopy within 4 weeks, or within 2 weeks? Or would you do a barium swallow, or would you do a CT chest? So I'll give you a few more seconds to get some more answers. Okay, most of you have got that absolutely right. So if we break down this question, this patient has a difficulty swallowing both fluids and solids. So this is quite a typical symptom of achalasia, and he also has regurgitation when lying flat. However, so this is a key symptoms of achalasia. Whereas esophageal cancer, for example, would cause a dysphagia, but it would cause dysphagia that's progressive. So because of an obstruction to the lumen that gets bigger over time, it can either be from the outside or from the inside. You initially start struggling to swallow solids, and then over time you progress to not being able to swallow liquids either. So because you can't exclude esophageal cancer clinically in this way, this man would be referred via 2-week wait pathway for an upper GI endoscopy. So he gets an upper GI endoscopy to rule out malignancy. And then once you've ruled out the most serious cause, you'd investigate for something like achalasia, which is less serious. So we've got causes of dysphagia. Inflammatory causes. So if you look all the way from the mouth down to the esophagus, you can get, obviously, tonsillitis and pharyngitis can cause painful swallowing. Esophagitis can be caused by loads of different things, including GORD, candida, different medications, and that can cause painful swallowing, and also ulcers. Mechanical causes of dysphagia would be something like a foreign body, obviously that's disrupting the lumen of the bowel. If you've got a stricture, such as a malignant or a benign stricture, that would cause obstruction, obviously. And then you can get compression from the outside, extraluminal, such as lung cancer, a rolling hiatus hernia, enlarged lymph nodes, etc. And then achalasia fits under the motility disorder causes of dysphagia. So locally, there is an issue with the passage of food from the esophagus into the stomach, caused by achalasia, and whereas with systemic motility disorders such as myasthenia or motor neuron diseases, they can also cause dysphagia, but they would also cause other neurological symptoms in other parts of the body. So what is achalasia? So it's an inability of the lower esophageal sphincter to relax, and it also has reduced esophageal peristalsis. It's a nervous system issue. It characteristically presents with liquids and solids not being able to be swallowed at the same time, and it can also cause regurgitation and weight loss. Chronic achalasia increases the risk of a patient developing squamous cell carcinoma. In terms of investigations, if a patient, anyone presenting with dysphagia, you would send by a 2-week wait pathway for endoscopy. Then you would do a barium swallow, which would show a dilated bird's beak esophagus. So instead of the esophagus being nice and even throughout its course, it dilates at the bottom because the sphincter is not relaxed, so the passage of food from the lower esophagus to the stomach is impaired. And then this would be the diagnostic investigation is manometry, where you measure the pressure in the lower esophagus and in the stomach, and there's a higher pressure gradient from the esophagus to the stomach due to this impaired relaxation of the lower esophageal sphincter. So in terms of management, you can always think about medical and surgical management. So medical management would be calcium channel blockers or nitrates, whereas surgical management would be something like Heller's cardiomyotomy. Okay, another question. I think this might be one of the last questions in my gastro section, and then we can have a little break. 52-year-old male presents to GP complaining of retrosternal pain that has been going on for around a year, but has been getting worse lately. He says it's usually better after meals, and he's been drinking plenty of Gaviscon, which has stopped helping now. He hasn't had any weight loss, and he doesn't have any dysphagia. His past medical history is only notable for back pain, for which he takes ibuprofen. On examination, he looks pale, but is otherwise stable. So from that history, can you identify which symptoms are red flag symptoms? Oh, thanks. Thank you for that. I'm just selecting random ones to muddy the waters. I think you all answered that pretty quickly, so we'll move on. The majority of you have got absolutely the correct answer, so it's the pale appearance. That's a red flag symptom, and the reason for that is that pale appearance is a symptom of anemia, and anemia is one of the alarm symptoms, which when you have new dyspepsia in over 55 years old, or when you have any of these alarm symptoms, and then you need to refer patients with dyspepsia for endoscopy again. So dyspepsia is a general term which can describe sensations of, for example, indigestion, abdominal pain after eating. It can be quite non-specific. But if you have any of these symptoms, like anemia, weight loss, anorexia plus or minus abdominal pain, a recent onset of symptoms. So in the question, I asked you whether the 1 year course of symptoms was concerning, but actually if it's more of a recent onset, it's more concerning. And obviously if someone's presenting with melena or hematemesis, that is concerning. Melena being passage of blood in the stool, and hematemesis being passage of blood in vomitus, just so everyone's on the same page. If those are present, that's suggestive of an upper GI bleed. So obviously that's a very concerning symptom. Causes of dyspepsia are various. You can get functional dyspepsia, which is common, where you have patients coming and complaining of this dyspepsia symptom, but they might be really, really troubled by it, and they might go to the GP many times about it. But actually, when you go to do an endoscopy, it's completely normal. Gastritis or esophagitis can be caused by H. pylori commonly, or alcohol use. Gastroesophageal reflux disease can be worsened by hiatus hernia. They can be caused by a lax esophageal sphincter. Ulcers in the stomach or in the duodenum can cause dyspepsia. Malignancies, achalasia, and medication. So the causes are various and varying. When a patient presenting with dyspepsia, you usually look at their medication list. For example, in this case, this gentleman takes ibuprofen. So if he's taking something that can obviously be a cause of dyspepsia, like an NSAID, then you would address whether the patient still needs to be on it, whether they can be switched to anything else, or whether they need to be put on a proton pump inhibitor to decrease the risk of an ulcer, a peptic ulcer. And so you look at their medications, and then you check for these alarm symptoms and refer as appropriate. So this is just a slide on peptic ulcer disease, which is very common. So you can get ulcers in the duodenum or in the stomach, and they can have different causes and different presentations. A duodenal ulcer is generally caused by H. pylori, and it tends to present before meals, or so like the pain is worse when someone is hungry, whereas when they eat, it gets better. So this is what was happening in our patient, where this guy says it's usually better after meals. So that's classic of a duodenal ulcer. Whereas a gastric ulcer tends to be worse on eating. And I always struggle to remember which way around those go. But maybe you can think that when you eat, the stomach fills up first. So the gastric ulcer would hurt more. That's how I remember it. So once you treat people for peptic ulcer disease, with H. pylori eradication therapy, if they're positive, or high dose PPI, then you need to do a surveillance OGD to ensure that it's resolved. Complications of peptic ulcer disease include upper GI bleeding, iron deficiency, anemia, and perforation. Okay, final gastro question. It's a 45-year-old man who presents to the emergency department after vomiting blood that looks like coffee grounds. He appears pale and sweaty and is still vomiting profusely blood into a bowl. He has a history of alcoholic liver disease. These are his observations. Which of these symptoms from the history, would score a point on the Glasgow-Blatchford bleeding scale? Is it the coffee ground vomiting? Is it the history of liver disease? Is it the systolic blood pressure of 105? Or is it the heart rate of 95? I'll give you a few minutes on that one. They're always difficult when they ask you to remember exact figures for these scoring systems. I always find that difficult. Okay, let's move on. So the answer to this one is a history of liver disease. So this is a Glasgow-Blatchford bleeding score. It's a very useful system to decide which patients can be discharged. So we had an interesting teaching session recently by a gastroenterology consultant about this. So Glasgow-Blatchford is not a very specific score because you can get points from it if you have lots of different presentations. For example, you get a point just from having a heart rate over 100. You can get a heart rate over 100 for a multitude of reasons. So it's not specific, but it's very sensitive in that it will pick up patients who are even a little bit concerning for worsening and for complications. So if a patient is scoring 0, then they can probably be safely discharged because it means that they're not tachycardic, their blood pressure is holding, their hemoglobin's fine, and they don't have any history that predisposes them to complication of upper GI bleeds. So it's a very sensitive and not very specific tool. So I like this diagram because it shows all the different causes of GI bleeding, actually not just upper but also lower. So I'm sure you know all of these already, but common causes of upper GI bleeding are bleeding varices, esophageal varices, usually caused which are present in patients with cirrhosis, liver cirrhosis. You can get gastritis, which can be hemorrhagic. You can get biliary vice tear in patients who've been vomiting profusely, and then the classic history with that would be if someone's been vomiting, for example, after a binge drink. They start vomiting. The vomiting is initially normal, maybe watery, and then after a few vomits, they start also seeing blood in the vomit. That's quite a classic history of biliary vice tear, because they vomited so much that they've torn part of their esophagus. Then ulcers in the stomach or in the duodenum can bleed. And then moving down into the small bowel, you can get bleeding from ischemic bowel disease, which can be usually in patients with peripheral vascular disease or history of stroke, or history of MIs, acute coronary syndrome, etc. You can get it from intussusception or Meckel's reticulum. And then moving on to the large bowel, you can bleed from cancers in the colon, and then from inflammatory bowel disease, such as UC, and then distally from things like an anal ship fissure, very, very painful condition. And hemorrhoids can cause, usually you get bleeding when you wipe with your tissue paper rather than bleeding mixed in with the stool. So in terms of management of people with upper GI bleeds, you'd start off with an A to E assessment. And again, you address all the abnormalities that you identify in your A to E assessment. You would do a PR exam, as was done in this case, to see if there's truly blood mixed in the stool, or maybe there's blood just in the anus itself from a fissure, or maybe you'll be able to see hemorrhoids on your examination. Then you do blood tests. Obviously, you would do things like a group and save, which identify the patient's blood group. So if they ever need a transfusion, you can do that. Clotting, to see if they have deranged clotting. If you were worried about, for example, a perforated peptic ulcer, you could do a chest X-ray where you can see air under the diaphragm, which suggests that there's a perforated lumen of the bowel. It's a very, very bad sign. You can transfuse them if they're hemodynamically unstable. Usually people give PPIs, and then there's specific management for variceal bleed, where you give broad spectrum antibiotics and terlipressin. So from the recent teaching we've had about upper GI bleeds, usually most of them actually resolve without the need for any management. And then they can get an OGD as an outpatient done, which is better tolerated, and it can see pathology better if it's not active bleeding. Obviously, if they're unstable, then you do need to take them for an OGD sooner. But in general, most upper GI bleeds resolve by themselves with no intervention. Okay, so that was the first part of the talk, which was on gastroenterology. So I'll give you 2 minutes break. That's not a very long break, maybe 3 minutes. So we restart at 1:45, and in the meantime, if you can fill in that feedback form, that would be really, really helpful. And there's also another chance to give feedback at the end of the talk. So I'll just give you 3 minutes. We'll restart at 7:45. Okay, let's start again. Hopefully most of you will be back. I have a question in the chat. Can someone remind me what toxic megacolon is pathology for? It's usually a complication of inflammatory bowel disease, including ulcerative colitis. So not an embarrassing question at all. So it's something that you want to exclude when you see a patient who presents with inflammatory bowel disease. So right, moving on to hepatology. Very difficult to summarize this, but we've just gone for key high yield aspects of the topic. So how does liver disease present? It can have symptoms such as fatigue, jaundice, bruising or bleeding, confusion. In terms of signs, so what you'd see in the patient, you'd see some ascites, so swollen tense abdomen. You could see caput medusae, which is what's shown in this picture on the bottom right of your slide. Dilated veins in the abdomen secondary to portal hypertension. You might see rectal hemorrhoids, which is, so the rectum and the esophagus are sites of varices which are caused by portal hypertension. And then you can get signs of hyperestrogenism, such as these spider nevi, which are in the top left part of your slide, and gynecomastia, pulmonary edema, etc. And then on an examination, you may also find hepatomegaly, which is an enlarged liver. I'm sure you know. Okay, next question. A 44-year-old woman is admitted to the emergency department with reduced GCS. An ambulance was called by a family member as she had not been contactable for a couple of days. We don't know much about her past medical history at present. On examination, she has a GCS of 8. Her sclera are noted to be jaundiced. Her abdomen is slightly distended, and there is withdrawal from pain when palpated in the right upper quadrant. And she has blood tests taken, which show the results on the right. So now we have to look at these results and then consider what is the most common cause for the suspected diagnosis. So we're looking at the blood tests, seeing what we think might be going on, and then what's the most common cause. So I'll give you a minute or so. Okay, not had many responses for this one. Maybe you're all getting a bit tired, but let's move on anyway. The most common, okay, so what do these findings show? Well, we've got a raised ALT, alanine transferase, a raised AST, and a raised bilirubin. So we're looking here at a hepatitis picture, and the most common cause, and this is a patient who's acutely unwell, so it's an acute hepatitis picture, and the most common cause for acute hepatitis is a paracetamol overdose. So that's the most common cause. And when you think about liver failure, you can break it down into acute liver failure, which itself is breaking down into different types depending on how long the onset of symptoms is. So hyperacute being less than 7 days, acute being 1 to 4 weeks, and subacute being up to 12 weeks. And then there's also chronic liver failure, which is can be caused by different pathologies. With acute liver failure, there's some investigations you can do for the most common causes. And then here, the slide also summarizes the appropriate treatment. So for a paracetamol overdose, you would do a paracetamol level. And then, as I'm sure you know, if the level of paracetamol is above the treatment line, then you would give treatment with NAC. If you have something like acute fatty liver of pregnancy or any of the hepatitis caused by pregnancy, the treatment for that is delivery of the fetus. Viral hepatitis is picked up on hepatitis screen. So I'm sure you know there's a lot. This comes up in exams a lot, but all the different antigens involved in hepatitis B, so the surface antigens, the core antigens, etc. And then similarly for the other hepatitis viruses, and you can treat them with antivirals. Wilson's disease is caused by a buildup of copper in the liver and also in other organs, and you can diagnose that by doing measuring serum copper, serum ceruloplasmin, which is a protein that transports copper, and urinary copper as well. And that can be treated with copper chelation or hemofiltration or plasmapheresis. Budd-Chiari syndrome is when there's a clot in the portal vein, which can be diagnosed with an abdominal ultrasound and with a Doppler, which shows the blood flow. And you can give anticoagulation to treat that, and you can do a TIPS procedure as well. Autoimmune hepatitis, you can do an autoimmune screen where you look for the antibodies associated with autoimmune hepatitis, usually treated with steroids. And finally, this is also hepatitis B, is a type of viral hepatitis. So similarly, there's antivirals to treat that. This is a very quick summary because it's a huge topic, but you can look into all of these different causes of acute liver failure in more detail and identify exactly how you'd investigate them and how you'd manage them. There's a specific slide here on autoimmune hepatitis because it does come up in exams and it's very difficult to remember. So there's 3 different types of autoimmune hepatitis. They're associated with different types of antibodies, and they tend to present in different subtypes of patient populations. So when you are suspecting autoimmune hepatitis, you would send off all these different antibodies. How to differentiate from option? Sorry, I just saw a question in the slide. So you wouldn't be able to differentiate. It's a good question. Paracetamol overdose from drug toxicity, just from the presentation alone, especially in this patient who is confused. And she's not been contactable. She won't be able to give you a history. She won't be able to tell you what she's been taking. But the question was just about what's the most common cause for the suspected diagnosis. The most common cause for acute hepatitis is paracetamol overdose. But you're right, it's difficult to distinguish in the history, absolutely. So in the interest of time, I'll leave you to look at the different causes of autoimmune hepatitis in your own time, also because it's one of those things that, unfortunately, me telling you probably won't help you remember. You have to kind of read through it, make notes or flashcards or however you revise. And then these are different causes of hepatitis. So alcoholic and non-alcoholic hepatitis. So alcoholic is, so this is how I remember it. You can measure the AST and the ALT. They'll both be raised in alcoholic and non-alcoholic hepatitis. However, if the AST is higher than the ALT, or the ratio of them is more than 2, then the alcoholic liver disease is more likely. And how do you remember that? Well, spirits, which is AST, so the S stands for spirits, is stronger than lager. So the AST will be higher than the ALT in alcoholic liver disease. That's how I remember it anyway. Whereas if the ratio is less than 1, i.e. the ALT is higher than the AST, then it's more suggestive of non-alcoholic fatty liver disease. Non-alcoholic liver disease is usually caused by fatty liver, so high triglycerides, obesity, these are all the risk factors associated. There's all sorts of different risk factors associated with a viral hepatitis. So A and E are the ones transmitted by fecal-oral route, whereas B and C are the ones that are more likely to cause chronic liver disease. It's really good to know about the serology of hepatitis B and how to identify acute or chronic infection with hepatitis B. That comes up in exams. And also you can identify from the serology whether a patient has had a vaccine to hepatitis B rather than has a previous infection. And then there's specific different treatments for different causes of hepatitis, of course. And I'll leave you to read that in your own time as well. Okay, another question. A 58-year-old woman is seen in hepatology clinic. She's been referred by her GP with deranged liver function tests. She feels completely well in herself and is asymptomatic. Her past medical history includes hypertension, hyperlipidemia, and type 2 diabetes. She has a full liver screen, which is unremarkable. She denies alcohol intake. Her BMI is 33, and she's referred for an ultrasound of her liver. So we want to know what is the most likely finding on her ultrasound scan. Is it normal ultrasound? Is it a thickened gallbladder wall? Is it a reduced liver ecotexture compared to kidneys? Diffuse hyperechoic ecotexture, or common bile duct obstruction? And I've been a bit unfair in this case. I haven't given you the normal ranges for the ALT, AST, and ALP. And I also don't remember them off the top of my head. But let me just to help you out. Let's just say that the ALT is more raised than the AST, and the ALP is raised as well, and the bilirubin is raised as well. obviously the HbA1c is above normal range as well. Okay, well done. The majority of you have got that absolutely right. So the correct answer is D, diffuse hyperechoic ecotexture. So this is an explanation as to why that's the correct answer. So in the question, we've got a few points that point us towards the diagnosis. So this is a lady with high BMI, hyperlipidemia, type 2 diabetes, who doesn't drink alcohol. So we think, okay, the most likely diagnosis is a non-alcoholic fatty liver disease. And the characteristic finding in this pathology is the diffuse hyperechoic ecotexture. There is a bright liver because there's fatty infiltration in it. A thickened gallbladder wall would be more typical in cholecystitis, which is not the kind of pathology that is described in this SBA. A reduced liver ecotexture it would be the opposite. So you see an increased ecotexture in the liver. So that's also caused a hyperechoic ecotexture. And then the common bile duct obstruction would be a cause of higher, more deranged ALP, and also a very different presentation. So this is a slide on common causes of, well, not necessarily common, but causes of liver failure or cirrhosis, which you have to know about. We've mentioned most of these before. You have to know sort of the associated factors that you need to know about for your exam. So, for example, that alcoholic liver disease is obviously associated with excess alcohol intake, and it can cause cirrhosis. But also that you can get cirrhosis caused by primary biliary cirrhosis and autoimmune conditions, which is associated with IBD. And also PSC is another associated with IBD, likely autoimmune disorder. You can get drug-induced liver failure by medications such as methotrexate, isoniazid, methyl-dopamine. Then you can get Wilson's disease and hemochromatosis, which are the buildup of hemochromatosis is the buildup of iron in the liver, and Wilson's is the buildup of copper. So there's just so many different causes, but it's all good to know about and learn about. So I'll leave the slide for you to look at in your leisure, and let's just move on to the last SBA of the talk. So you've got a 54-year-old man in this case who attends a GP with his wife, feeling generally unwell. He has a history of non-alcoholic fatty liver, for which he has been lost to follow-up from the hepatology clinic. He describes malaise for several months and a feeling of weakness when he exerts himself. On examination, he is disorientated with an abbreviated mental test score of 6 out of 10. He has excoriation marks on his arms and torso, but no evidence of jaundice. He has a mild discomfort in his right upper quadrant on palpation of his abdomen, and he's lost 2 stone since his last clinic appointment. So we want to think about the symptoms of advanced liver disease in this case. Which ones of these are most concerning? Is it weight loss, right upper quadrant discomfort, weakness, confusion, or malaise? I think we might have lost our so our room should do our poll. So I'm just going to quickly do one. So I'll get you guys to answer this last question as well as you can. Oh, you had already answered it. Sorry, I didn't see that there was already a poll up. So most of you had already answered it previously. Well done. Answering D for the majority of you, which is absolutely correct. So confusion is a sign of a complication of chronic liver disease, which is hepatic encephalopathy, which is caused by a buildup of ammonia in the blood due to impaired breakdown of ammonia by liver. So that can cause confusion, and it's a very serious complication of chronic liver disease. Other complications of liver disease would be esophageal varices, which can cause an upper GI bleed, ascites, which can cause spontaneous bacterial peritonitis, which is a very bad infection, difficult to treat. Hepatocellular carcinoma can be a complication. Encephalopathy we've discussed, and coagulopathy. So the liver synthesizes many of the clotting factors. So when you have liver disease, sometimes you can get coagulopathy, impaired clotting. Patients are more prone to bleeding, and this can be a serious complication as well. And that brings our presentation to a close. So thank you for listening. We've covered the first part of the talk was on gastroenterology, and we've covered different causes of diarrhea, causes of dysphagia and how to investigate them, causes of dyspepsia and upper GI bleeding. And in the hepatology section of the talk, we covered presentations of liver disease, causes of acute and chronic liver disease, and complications of chronic liver disease. So thank you for listening. Again, here is your feedback form as a QR code, and if you complete it, you can get a certificate of attendance. The next talk by Mind the Bleep will be a hematology talk on the 6th of November, as far as I understand. And if you have any questions, email this email finalyear@mindthebleep for any questions. But I can also see there's 2 messages in the poll in the chat. Sorry. So got you. So do we do an endoscope for a patient with peptic ulcer disease without any of the red flag signs for diagnostic purposes? Basically, it's diagnosis of PUD, a clinical diagnosis. So it's a good question. So what you would do is you would initially treat it conservatively. If you suspect peptic ulcer disease without any of the alarm symptoms, you would first treat it conservatively with a trial of PPI treatment. Let me find the appropriate slide to go back to. Here, so initially you try a high dose of PPI treatment for 6 to 8 weeks. If that doesn't resolve the symptoms, then you would send them for an endoscopy, for an OGD, to evaluate if there's any other causes of these symptoms, specifically malignancy. Hopefully that answers your question. Let me know if not. Do we get a copy of this presentation? If it does resolve, do we still do OGD? No, you wouldn't, because you've treated it clinically. And do we get a copy of this presentation? I think that you do if you've completed the feedback form, but Romsha's gone, so I've lost my guide. I'm sorry, I'm not too sure. If not, you can definitely see this presentation recorded, and you'll be able to see the slides from there.
Elena, sorry, I'm here, but I just missed what was the question?
I thought you were gone. Sorry. Someone's wondering if they get a copy of the presentation.
So this whole lecture is recorded, so we'll be uploading it onto YouTube as well as Medall at a later date. So yeah, you should all be able to access it on there. It might just take a few days / a week or so to come through, but yeah, it should all be available afterwards.
Oh, thanks, Rimsham. Great. Okay, if there's no other questions, I'll close this there.
Thanks, Elena.
Yes. Oh, thanks, Ramsha. Take care. I'm gonna go. Bye.